Thanks for coming back. Now the committee members and I are going to discuss what we've learned throughout the day from the various presentations and Q&A sessions. We still have more presenters and a panel discussion tomorrow, but I want us to reflect on what we heard today. After we conclude this series in September, as I mentioned earlier, we will submit a report to the Secretary of Health and Human Services on population-based total cost of care models. Our reflections at these meetings will help shape our findings in that report. So to the committee members, I'm going to ask you to find the potential topics for deliberation document in the binder, and then either use the hand raise feature in WebEx or simply raise your hand as we begin our discussion. We have the slide up currently for those participating in the public meeting that identifies some of the potential topics for the committee's deliberation during this March public meeting. So I'll just run through them and then we'll take them down. So potential topics include, defining and structuring population-based total cost of care models, challenges in developing and implementing population-based total cost of care models for physician practices, equity implications of population-based total cost of care models, payer variation in population-based total cost of care models, and then promising approaches related to care delivery, payment, and performance measurement. So you can go ahead and take the slide down, and so we can see all the committee members. We'll just open it up for comments and questions about what we've heard so far today and any other comments you may have.
I thought it was a very good discussion today with a lot of really important themes being pulled out. One thing I'm struck by is the opportunity to really look to states like Oregon and Vermont, who already are creating or on the path to integrated all payer models, and really pulling out the themes of success and the innovation coming out of that, and that being really important patterns to look at as we look at total cost of care.
Yeah, this is Angela. I would agree with that. I thought the presentations were exceptionally well done today and covered very important topics. And what struck me is that this is achievable at a state level and an all-payer level, and hopefully we can develop some models that can attract an all-payer model to create that scale that the providers need to really engage in this. So that was good to hear.
Other thoughts? Lee, as you think about your work in Oklahoma, I'm just curious from what you heard today, how this resonates or any particular challenges you think about when you heard the conversation today.
Appreciate that, Paul. Yeah, my thoughts actually were going two different places, which I've experienced and we're working in, but both of which remain murky, which is one I'm fascinated by the, kind of the clear, evocative description of a nesting of, baseline broad population-based total cost of care model, then with other focused population or episode models, kind of under that umbrella. And we heard from Dr. Fowler, potentially dialysis could be an episode model. That makes good sense. We heard from multiple speakers about lower limb joint replacement. I think that makes good sense. My brain also would include perhaps hospice populations. So I guess I was wondering what, if that model is a working construct, what other most tightly defined, episode or specific populations would we want to have a separate nested model out and pull, potential exceptionally high cost, high risk people out of a population-based model. So that was the first thing, and I'll let the committee kind of reflect on that. And then I was going to go towards risk adjustment next.
Thoughts on that from other committee members?
I like those models. I think that's necessary to figure out how to nest those things within a total cost of care broad population model.
I agree, Lee and Angelo, and I think I was referencing in some of the comments, there's also the social determinant sort of aspect of that. So there's this emergence of equity-backed total cost of care population approaches to homeless populations or justice-involved populations, which is a very different way of thinking of it, rather than disease-oriented standpoint. But it does make sense when you look at the experience of the population and offer some real interesting opportunities for integrated care.
Mhm.
Josh, I've been just kind of react a little bit to Lee's comment, and actually many of the ones that were said this morning, I've been kind of processing and noodling on these. So much good information there, and I think one of the comments that struck me was this idea that you know, X intervention or Y solution doesn't work all the time. There has to be some targeting. You know, in that way, you have to deliver to the right population, and to just draw a rough analog. That to me is what, when we're talking about nested or coordinated models, that's what episodes are. Right? One of the challenges of that broad population is you could go after one of any N areas. And so I really like that idea. I think where like the proverbial rubber meets the road for me is, as I look at models in the past, little things like multiple models will have sniff waivers, but they'll vary just enough they don't plug right. You know, there's no USB, so to speak, we can plug these in. And I think if we're going to go forward here, we'll need something to where, in my opinion, it would be beneficial to think about a set of things, whether it's risk adjustment or benchmarking, or, you know, we could think of a few things that someone could say, within my population-based model, I would like to plug in these 2 or 3 episodes, right? Because it's not also just what is most fruitful from a, you know, national perspective. I think a few people mentioned this idea that you may not have enough patients for your population, right? So that flexibility to be able to target is important, but I can't make everybody target everything. And so to me, like, we're not going to be able to do that unless we have some standard set of payment features, which maybe we'll talk about in the next few meetings here, to let us do that. I think short of that, that will remain an idea.
Thanks, Josh. Other thoughts on?
Yeah, this is Bruce. Actually, the space bar is not working for me to get off mute. I don't know if anyone else has that problem. I agree with others. I thought the presentations were very good, and they were meaty, which was nice. I did notice that the actuaries were made reference to a few times, and earlier this morning, I mentioned maybe having the actuaries represented. By the way, the actuaries, as you know, are people who are pretty good with numbers but don't have the personality to be an accountant, right? Are there any actuaries in our group? I'm sorry. But just to get a sense of how they look at it, that they're looking at all of these issues related to total cost of care as we are. I think it might tee up some good discussions about methodology, which may be focused on in the September meeting. But I think we need a lead into that those discussions in the June meeting. So I'm going to reiterate my suggestion that to have the actuaries represented at that meeting seems sensible to me. And it makes even more sense to me having heard the presentations that we just did.
And
Great.
Bruce, tomorrow, Tori Fields is part of the presenters, and she's an actuary. And
Oh
is
boy.
articulate about this. So it'd be really interesting to ask her a few follow-on questions tomorrow.
Right. And I sure am glad I didn't make my joke tomorrow instead of today.
Thanks for that, Bruce. Other thoughts?
Well,
A couple
I
of
think
things.
we did.
Oops, sorry.
Ginny.
Oh no,
Go
go ahead, Larry.
You know, I think I'm coming away from this morning with a definition of total cost of care. In fact, it's more inclusive than I might have thought even before the meeting started. So, I mean, that's our major goal of these 2 days, is to define what that is, so that then we can look at models and programs and, you know, make some structure. but they had a very inclusive concept of total cost of care.
Yeah, and that's almost exactly what I was going to say, Larry. A couple things that struck out, basically just stood out anyway at me were one, that their definition of total cost of care was very inclusive, and that seemed pretty uniform. That the thought that if you included everything, you actually led to more innovation seems to be the message. Two, the social risk adjustment, I thought was a great way to think about how you embed social equity or health equity into programs. And then the third message that I took away was, the concept of harmonizing the APMs and then, as alluded to earlier, nesting within the APMs. And I think that, that needs some modeling to really see how that would play out. But I thought that was a great message as well.
And this is Angela. I like the conversations around the total cost of care, but I just want to point out that in my opinion, smaller, particularly physician-only ACOs are going to have a really difficult time taking risk for pharmaceuticals in those type of ACOs, and so we will have to make some exceptions to the definition, based on the application.
Mm-hmm.
Yeah, Angela, the expensive drugs are either in or they're all out, whether they're in the medical claims or in the pharma claims. This siloed approach here where, I look at my space, infliximab and vedolizumab are in medical costs, but Stelara and Humira are not because they're self-injectable. And I've always taken the position that you either include them all or you don't include any of them. But to have half of them in and half of them out makes no sense. And that just allows people to play those markets and patients suffer in the long run.
Yep.
We're trying to this idea of the nested models a little bit too. I just want to also kind of surface this idea that, if you talk to ACOs around the country, it's not that none of them are targeting. I mean, I think a lot of them do that already. They implement programs to target specific populations. And so one could ask, a systematic episode-based model overlaid or kind of as one track or one component of a population-based model, there's pluses, there's also minuses to that, right? And I very much, I trust the group knows this from my perspective, very much value evidence and using that to inform our decisions. However, we also don't penalize ACOs for the programs they do now that work or don't work, right? We don't legislate that and say, well, you shouldn't go after your hospice population or your CHF or your multi-morbidity patients. We give that flexibility. So I just want to call out that if we nest and lay these tracks down, we are losing some of that flexibility. Just have to grapple with whether that's good or bad.
I think another interesting theme that came out, and this is related to Larry's presentation, but also looking at total cost of care type of models with, for example, hospice care, which is based on, any models where you're holding all costs of care for a certain rate, but that the importance of anticipatory management of conditions and experiences, and then a pathway for addressing that before it becomes a crisis is so important for design of the system. So the perpetuation of that in total cost of care models in all directions is critical.
Other thoughts and comments? I was wondering, we heard a little bit about MA today, and I'm wondering whether, based on some of the discussion today, is it worth learning more around the MA programs and how they try to, again, create their networks and identify how specialists interact, or if that would be helpful in our thinking.
I think there's a lot to be learned from them, Paul. It's a great idea. Now, in the June meeting, I think we have scheduled a couple of sort of provider-facing organizations that largely deal with MA, and that might be a good way to develop that thought process.
I think it's a great idea to actually just kind of list out all the things that we could learn from them, and things that won't translate, just to have that distinction. For example, certain things like networks, it just won't be, for a number of different reasons. But other ways in terms of beneficiary engagement, I think great. So yeah, I agree with that idea.
Other thoughts? I know, and Lauren, you may have a comment on this, that, we talked a bit around social determinants of health and whether, the best way to implement that is, should it be medical systems providing the social benefits, or should it be the collaboration with social service systems? I know you think about this a lot, so curious what your thoughts on that.
I thought there was great discussion about that. So, I spend so much time in that space. I have a very biased opinion, I think, so about the need to really invest in our social delivery systems. Screening isn't enough. What we see around the country is a lot of screening and navigation to nowhere. The services don't exist and they're not financed to meet the need. So if we don't include that in our total cost of care purview and discussions, we're going to end up just creating another cost source. And how will that be addressed? So the most successful and interesting models I'm seeing across the country are integrating that. I also think that partnership to that is really important. I see people reinventing the wheel and starting services when they already exist in a market. They're authentic to the culture. But I'm curious what others thought on the call. We heard some really great comments about that. And I think it will continue to be a really big area of discussion, and something that we're going to struggle with this as a country about where are we going to invest and where are the dollars going to go.
Yeah, I mean, the challenge is going to be that it increases. It's not a budget neutral proposition in a lot of situations, right? So you're covering additional care. And so then it goes back to how you define total cost of care. If it's just Part A and Part B, that's not something that is easily amenable to being budget neutral to include social determinant help. But if you do a global fee or total cost of care that encompasses everything, then you allow for people to be able to spend their money as they see fit, which oftentimes contributes to being able to spend money on social determinants.
Yeah, just to follow on that, I think linking Mike Chernow's idea of flexibility in creating efficiencies, total cost of care, if we, for example, include Part A, Part B, plus minus Part D costs as a total cost of care, that would be the total cost of care, but how the organization allocates those dollars, including to social determinants of health resources, like transportation needs for dialysis patients, could be up to the organization, but that doesn't really add on to their total cost of care. That total cost of care should be the total cost of their healthcare expenses, but how you allocate those dollars can be more flexible, I think.
And one thing I've been struck with on this is the length of time to assess success or failure of these programs. And it may take longer to realize a return on investment when you're building SDOH services in. They may not pay off at the same rate, but that doesn't mean you don't do them.
Lee, I think you had a comment.
Yeah, that just circles back around to risk adjustment. I do operate a high quality MA plan, and this concept of social determinants being so critical. I love the comment that it's necessary to do the screening, but it's not sufficient. It's what you do with that information that makes the difference in members' lives. And the best risk adjustment models now only elastically kind of account or predict about 50% of the variance, give or take, and none of them really account for social determinant findings that seem way overweighted in what happens with a person's healthcare costs. So from the health plan side, as I'm gathering all this data and systematically building care teams to react to it, I'd like my revenue to reflect the appropriate risk of the population and the things we're knowing and finding and taking on. And then my provider operator brain is saying, and for the provider teams, they need payment that fully reflects the severity of their patient population, which really just was never recognized. And so I think I'm a pragmatist at heart, but I think there's a lot of academic work and statistics to be done about modeling how risk adjustment models reflect social determinant work, and that can't take a decade to do. We need to figure it out pretty quickly.
Yeah, thanks for those comments. Other thoughts?
Is merging related to that is some really interesting AI-driven utilization of related health needs and social determinants of health, and really tiering populations and predictive models based on that, just like we've kind of done with disease management, really looking at those social factors and being able to tier that out. So I have great hope that that's coming forward.
Other comments?
Another thing that struck me, Paul, that really didn't come up today, but in our total cost of care construct, we had nobody today that mentioned anything about, proven clinical or other service outcomes, quality metrics, pay for performance, et cetera. And to some degree, that's perverse, and everybody's used to pushing on quality metrics as substitute endpoints. But really, in a total cost of care model, there's still going to have to be some breakers or some waypoints that assume, some standard minimal level of quality is met for the total cost construct to be valid. And I think there's more thinking to be done there too.
Yeah, I agree. And at what level is the attribution on those quality measures? All the usual concerns around all of that.
Right.
Yeah, it's a good point. Very good point.
And that then parlays into essentially some kind of coordinated all payer mechanism. As long as you're picking at it one payer, one program at a time, you'll never have the volume to change practice.
Yeah. On the topic, I don't know, maybe because I'm a specialist, I'm always focused back on the specialty and within the total cost of care. I just any other thoughts around that? I mean, you've already mentioned some important points, and as Walter said, Mike Chernow mentioned about flexibility and not being too prescriptive and not trying to drive everything policy-wide, because people can often look for ways around, to either pick populations or do things differently. But is there a sense that that most of the specialty care would be sort of sorted out within whatever entity is taking on the total cost of care, as opposed to prescriptive episodes, other than some of the ones that have already been mentioned? Is that the sense, or do I have that wrong?
I think you have it right. I also like Larry's construct of how you identify what kinds of chronic illnesses are appropriate for nesting within a broad-based ACO-like operation. In fact, you said it was published, right, Larry? So maybe
Yes.
we can.
I'll send it to you.
Okay.
I'll send it to you. I know where it is. They would have to look.
Okay. All right.
No, it's like we deal with specialties, and patients have characteristics that go across specialties. And there may be a different science around creating which patient populations we should promote the development of nesting solutions. Because if I'm speaking as CMS, if we're on the hook for providing the total cost of care for these patients, it might not fit into specialty categories or type of physician categories. We may have to start with it from a patient characteristic point of view.
I think that's
Lauren was speaking about earlier.
Yeah, my belief is it's the ACO's responsibility to create service line-like entities across the ACO that brings those multiple specialties together that focus on certain disease areas that, to your point, may not be purely cardiology or purely pulmonary. It takes primary care at the table and rheumatology at the table and others at the table that are driving those care models and looking at those outcomes.
Yeah. And then having worked deeply with all the subpopulations who are complex, there's certain subgroups where they really identify their primary care, for example, in sickle cell as their hematologist, or particularly COPD with their pulmonologist, because they're spending so much time there. So who holds that role and how does that nest? As well as the people who need the truly integrated specialty care where they have multiple specialists and primary care really sitting at the table. Very important question, I think, for the future. From the patient perspective, who they see as their quarterback or of their care may be very different than how we have designed the system.
I really like this conversation, but I think, this may be something that we can flesh out in future sessions too, but some of what we're articulating here, that flexibility exists today, right? So I just want to say, like, when we're talking about nesting a model in a model, and each model has its, analogous structures, and maybe that's this conversation has kind of expressed it more elegantly than I could have, but that's the trade-off, right? To Angela's point about those service lines, if you create a model, it creates restrictions around that. And we could ask, how is what we're describing now different than what could potentially exist today in a large broad-based ACO?
That becomes also really relevant with the serious persistent mental illness population. So who do people anchor to the most and where do they spend the most of their time?
That's great. We just have a couple of minutes left. I want to be sure we capture everyone's comments and thoughts. Of course, we'll be back tomorrow for more, but I thought all the presentations from the panelists and then from the PCDT, and Larry did double duty doing projects. So I mean, it's just really terrific, and the conversation with the panelists I thought was really, really helpful.
Larry, you get the MVP award today.
Yeah.
Well, if you want to learn how to swim, you got to jump in the pool. So I figured I may as well do it. Thank you.
Yeah. So I want to thank everyone for participating today, CMS leadership, our expert presenters, my PTAC colleagues, and those listening in. There's a lot more to cover related to population-based payment and total cost of care models. So we'll be back tomorrow morning at 11 a.m. Eastern Time. We'll feature another listening session and a roundtable panel discussion. So I hope to see everyone back then. Thank you. This ends our meeting for today, and we'll see everyone back tomorrow at 11 a.m.
Thank you.
Great. Thanks. Bye now.
Produced by the U.S. Department of Health and Human Services.